Hello everyone, my name is Dr. Beatrice Morita. I'm a primary healthcare physician and I'm currently doing my postgraduate diploma in endocrinology. Welcome to this video on identifying thyroid nodules with malignancy potential. The objective of this video is to give a comprehensive overview on the red flags and diagnostic approaches for thyroid nodules. This video is especially useful to healthcare workers and medical students because we'll also get to discuss the referral guidelines for thyroid nodules. Firstly, we would like to understand what thyroid nodules are. These can simply be defined as an overgrowth on the normal thyroid gland, which is radiologically distinct from the surrounding thyroid tissue, and physically it can be seen as a lump in the neck. About 90% of these thyroid nodules are benign and asymptomatic. However, 4 to 6.5% can be malignant, and about 5 to 7% of these nodules can be palpated either by the patient or by the physician, but 20 to 76% are incidentally found on the ultrasound. So why should these thyroid nodules be evaluated? The main aim of evaluating is to exclude malignancy. So on physical examination, the goal is to check the size of the thyroid nodule and to check if there is change in size over time. You also check for the consistency. Is it cystic or is it solid? Is it solitary or there are multiple nodules? Is it fixated to the adjacent tissue? And is there cervical lymph node involvement? You also check if there is mobility of the thyroid nodule and if there is tenderness. So when should you be worried when you have thyroid nodules? These are what are called red flag signs and symptoms for malignancy. When a patient is presenting compression symptoms, usually when the thyroid nodule overgrows, it causes compression of structures in the neck, and this leads to signs and symptoms like cough, dysphagia, dyspnea, vocal cords paralysis, hoarseness of voice. And when a patient starts presenting palpable cervical lymphadenopathy, when you also see a rapidly enlarging mass, which is painless, firm, fixated to adjacent tissues, and when a patient presents clinical features of thyroid dysfunction, these could be either hypothyroidism or hyperthyroidism. Some of the classic symptoms of hyperthyroidism include weight loss, heat intolerance, diarrhea, irritability, and heart palpitations. And hypothyroidism includes weight gain, cold intolerance, apathy, menstrual irregularities, and constipation. What are some of the risk factors associated with malignancy? Patients with previous exposure to radiation, which could be head or neck radiation, adults that are above the age of 40, and children that are less than 10 years. The male sex. As thyroid nodules are 4 times common in women, it is worrisome when found in men. Presence of cervical lymph nodes, rapidly enlarging nodules, family history of thyroid cancer or thyroid adenoma, L-thyroid status, patients with endemic goiter, the thyroid size more than 1 centimeter, the Cowden syndrome, and family history of endocrine cancers. Some of the important investigations that help in evaluating thyroid nodules are shown on the screen. Thyroid stimulating hormone is the first investigation which helps check the functionality of the thyroid. Results that show low and suppressed thyroid stimulating hormone with elevated T3 and T4 levels points to hyperfunctioning thyroid, which will require a thyroid iodine uptake scan for further evaluation, while results showing normal or elevated levels of thyroid stimulating hormone are concerns for malignancy, which will require an ultrasound. Ultrasound is able to check the shape of the thyroid nodule, whether it is cystic or solid, and whether it's solitary or multiple. The picture on the screen shows sonographic features of the thyroid. Some of the characteristics of the benign thyroid nodule are cystic, spongiform, isoechoic or hyperechoic, and interrupted eggshell calcifications, while features of malignancy are microcalcifications, taller than wide shape, irregular borders or margins, hypoechoic, extrathyroidal extensions, and interrupted eggshell calcifications. These features are best interpreted by a radiologist. When features of malignancy are detected, the patient is sent for fine needle aspiration cytology. This is a procedure of choice for evaluating thyroid nodules, which is able to tell whether the nodule is benign or malignant, and this can be ultrasound guided. The following are the guidelines for referral to specialized care by the primary healthcare physicians. Nodules that can be managed by the general practitioner are those that are less than 1 centimeter or incidentally detected on ultrasound, and these do not change in size over years, and when a patient does not have risk factors for malignancy. The plan in these cases is watchful waiting with physical examination, thyroid function test, and ultrasound. The interval for monitoring these patients can either be between 12 to 24 months. However, the intervals can be increased if no change is noted over time. Non-urgent referrals are those that present with either signs of hyperthyroidism or hypothyroidism. These should be referred to the endocrinologist. Nodules that enlarge over months, the presence of sudden pain, and an enlarged mass. The thyroid nodules that have to be referred urgently are those presenting with cervical lymphadenopathy, rapidly enlarging nodules in days or weeks, patients with risk factors for malignancy, presence of hoarseness of voice, or presence of a nodule in a child. Nodules that have to be referred the same day are those that present with stridor plus thyroid lump. Referred cases are usually discussed and assessed by a multidisciplinary team, where a definitive treatment is reached. Some treatment modalities include surgery, hormone replacement therapy, radioactive iodine, radiation, and chemotherapy in some cases. We have come to the end of this video. I hope it has been informative. Thank you very much for watching. See you next time for more educational videos. Goodbye.